Okay. Everybody, we will get started with the last session of this conference, but the most important session, which is, of course, hepatology. We have three very good speakers for you today, and we're covering some very interesting topics, including alcoholic liver disease and treatment of alcoholic liver disease within the GI practice. We're also covering drug-induced liver injury, and then finally, personalized treatment for hepatitis B. Our first speaker today will be our guest speaker who's coming all the way from New York City, Dr. Jean Im, who is an associate professor of medicine at Mount Sinai and really one of the pioneers of liver transplantation for alcoholic hepatitis in the United States. Previously, this was really being driven by the Europeans, but he's one of the first persons to actually drive the narrative within the United States, so we're very lucky to have him. And Dr. Im, if you'd like to get started, I'll bring you up here. Let's give him a warm welcome. I thought we do it in the end. Okay. Sorry. My mistake. Before we start, I thought we were doing this drawing at the end of the session so that everybody stays. But we will do the drawing now, so the winner gets a $200 Visa gift card. Okay, and the winner is Sasan Sultani. Okay, come on up and you can get your gift card. Okay, and now Dr. Im, you can get started.
Thank you, Vinay. I was hoping to get both, you know, the prize and the talk. So thank you to the course directors for inviting me to speak to you today. I'm tasked to discuss things that are very different than the previous sessions, which is things about alcohol, right? And integrating alcohol addiction screening and treatment into a busy GI practice. I don't have any disclosures, but I will discuss some off-label use of medications. So here's the outline of my talk. Essentially, I'm just going to try to give you a landscape of alcohol-associated liver disease, some changes in diagnosis and definitions, and then talk about screening and treatment. I'm hoping to try to convince you that alcohol is very, very important, even those who don't really see liver patients so much. So there's been some proposed changes in terminology, and we're moving away from kind of older, outdated, pejorative terms like alcoholic, and now we're calling our patients with alcohol use disorder, away from recidivism, which is really more of a legal term, right? When we talk about relapsing, remitting, we don't really use the term recidivism, right? In that, and we really want to call it relapse. This is some proposed changes in the latest AASLD guidelines, as well as from the European guidelines, and so. It's a little bit more wordy, but we're going to we should be shifting our terminology, and you're seeing this in publications now, alcohol associated and the various terms. So when I was in training, it was the DSM-4, but now it's the DSM-5, and we've gotten rid of the terms alcohol abuse and alcohol dependence, and now it's all under the umbrella alcohol use disorder, AUD. And we really should be using this terminology because that's what the psychiatrists use. And they're now 3 different tiers: mild, moderate, and severe. So those are the updates in terminology for the most part. So before I go and talk about the potential dangers of alcohol, I wanted to be a little fair and talk about the potential benefits, right? And this is what makes alcohol a little bit trickier in terms of discussions with our patients. So it's a bit of a proverbial double-edged sword. So there are favorable aspects of alcohol, such as with moderate drinking, it may improve cardiovascular health. And then the unfavorable, which many of us are familiar with, excessive drinking is toxic to the heart and the 3rd leading cause of premature death among Americans. So let's talk a little bit about the potential positive data, right? So you can see in this slide the rather famous J-shaped curve of alcohol, all right? It's often cited. So if you look at this meta-analysis that is often published or presented, you can see that relative to the all-cause mortality, the number of drinks as you go higher per day, it actually improves all-cause mortality, according to this study. And then it starts to cross the line when you get to 1 or 2 drinks a day. So perhaps there's some salutary benefits, effects of alcohol and health. Now, there's been a newer study it's a very elegant, complicated study looking at basically publicly available data and studies, in 195 countries. And in this separate analysis, they also found, again, this J-shaped relationship between alcohol and ischemic heart disease. You can see the curve starts to go down at 1 or 2 drinks, right? Meaning it improves ischemic heart disease. However, if you look at it in other disorders, such as breast cancer, that curve actually goes up with a single drink. And if you look at it more worldwide, away from the Western populations, tuberculosis and infections also is impacted negatively with alcohol. So if you take it all together, though, this study has shown that there really is no benefit of alcohol, even a single drink, in terms of improving all-cause mortality when you take it in the lump sum. Okay, so basically all alcohol is not safe. Now, that being said, we also take risks by, in New York, I say, you cross Fifth Avenue, there's a risk of doing that. You fly, fly somewhere, you drive somewhere, there are some inherent risks. So, you have to take it a bit of a grain of salt there. But I do think it does show that, unless you have a patient in front of you who their primary risk is ischemic heart disease, you have to be careful in promoting alcohol as beneficial. So what is safe drinking? Drinking in moderation. So these are updated guidelines from the government and NIH. So many of you probably know that it's set at 1 drink a day for women, 2 drinks a day for men. Sometimes the units of alcohol can be kind of tricky. And so I think many of you in the room have had a drink in a solo cup before. And I found this on the internet, which is kind of interesting. So if you take that bottom rim of the cup, which is very, very small, right? That's about 1 ounce of liquor, all right? The definition of a single drink of spirits is 1.5 ounces, right? So that's a very, very small amount of volume, right? And most people are drinking much more of that and saying that's 1 drink to them, right? When it's actually much more than that. So the units can be very difficult for us to calculate, unlike viral loads, for example. Right. So this data of the 1 or 2 drinks a day comes from large, older population studies that demonstrate that the more you drink, the more likely you're going to develop alcohol-associated liver disease. And you can see for women and men, the curve is very different in terms of the slope of the curve at a certain number of drinks per day. So newer data about this, tries to evaluate the question of if the certain kinds of alcohols and whether I drink it with meals, whether that makes a difference. And so this is the Million Women study in the UK. A very large study of about 1/4 of all women in the UK. They found that there was a similar increased relative risk if you drink more than 1 drink a day. Although the effects were a little bit less in beer and spirits, I put wine here because this is the most impactful result, that if you drink alcohol with meals, it actually reduces your risk of developing liver disease, particularly with wine. Okay, so it sort of protects you. And that is, it helps us understand the data in relative to the lifestyle of the Mediterranean diet, or the French, where Italians, where alcohol consumed during meals is quite common, and yet you don't see a large impact of alcohol-associated liver disease relative to the amount of drinking that happens. So I'm going to switch back to alcohol use disorder. Okay, from 2002 to 2013. This NESARC study demonstrates that over that period of a decade, alcohol use disorder, the prevalence has increased significantly, about 50%, right? And in the lifetime of an American, about 1/3 of patients will have met the definition of alcohol use disorder. So you're going to see this. And also, these NIH investigators demonstrated that the highest increase in alcohol use disorder occurred in those who we wouldn't think be susceptible to alcohol injury. So, lower socioeconomic class, older adult minority women, for example. So this is not necessarily a disease of older Caucasian men anymore. Now, it's not a surprise that the increasing prevalence of AUD will then have later effects on the prevalence of alcohol-associated liver disease, all right? And these are some studies from CDC data showing that there's been a significant increase in cirrhosis deaths, and a lot of it was driven by young patients. Many of you who are around in the hospital, you've probably seen this recently, especially post-COVID. If you look at just private insurance, there's also data coming from the Michigan group showing that the prevalence of alcohol-associated cirrhosis in women has also alarmingly risen as well over the similar time period. And then came along COVID, right? So that was the landscape before COVID, and then COVID hit. This is where I practiced, Mount Sinai Medical Center, and this is Central Park, which is adjacent, and these, this emergency field hospital. That was set up. So these are hopefully times that we won't go back to, but it should be not surprising that COVID, the stay-at-home orders, social distancing, they all exacerbate alcohol use disorder and challenge those who are in remission. So basically, this whole scenario really influence factors associated with relapse and sustained abstinence. Now there's some robust data that demonstrate what we sort of all expected, okay? That we were drinking more, or at least we were buying more alcohol, all right? So this paper that came out from Brian Lee, USC, and Annals showed that people were buying a 34% increase in alcohol, more cigarettes, also more non-alcoholic beverages, but perhaps this is just hoarding of alcohol, people, in terms of concerns about the supply chain rather than actually drinking it. But now we have data that shows that we were drinking it too, okay? So this is the NIH study that just came out using CDC data. There was a 25% increase alcohol-related mortality during COVID, which outpaced all-cause mortality, which was about 17%. And the greatest increase in alcohol-related deaths were in women aged 35 to 44, sort of young, prime of their lives kind of situation. So this is the scenario in which we see ourselves practicing GI and hepatology, right? So I'm trying to argue that we should be screening for alcohol because drinking is very, very common, all right? 3/4 of all the US adults have had alcohol in the past 1 year. About half have used it in the past month, and about 1/4 have used it binge drinking in the past month as well. I won't go through all of these theories about increased drinking, but essentially there's a lot more choices and it's becoming socially much more acceptable as well. And then you got COVID. So, in a room full of mostly gastroenterologists, we should be screening for this in all of our patients, right? So many of you are familiar with the CAGE score. It's okay, but it doesn't really get to the amount of alcohol and how that might affect, liver health, for example. So we really should promote something called the Audit C, all right? Just 3 questions, all right? How often do you have a drink containing alcohol? How many standard drinks containing alcohol do you have on a typical day? And how often do you have 6 or more drinks on one occasion, okay? If that is too burdensome because, we're busy and we have to see a lot of patients, stick to 1 question, single alcohol screening question, SASQ, okay, which is basically an adaptation of question number 3. How many times in the past year have you had 5, if you're a man, 4, if you're a woman, or more drinks in a day? And if the answer is 1 or more, then that's a pretty good assessment for that this patient in front of you has alcohol use disorder. I think if you can distill it down to 1 question, we all can do 1 question. We all have time for that, okay? If screening verbally is a little uncomfortable or you don't have time for it because you're busy doing other things, then you can check a new test, relatively new test, that I think is the best alcohol biomarker currently. It's a serum phosphatidylethanol, or a PEth test, okay? Very high sensitivity, high specificity. It's a blood test, so you don't have to worry about whether the patient can urinate or not, or whether they can kind of get around that. It detects regular heavy alcohol use for up to 2 to 3 weeks Okay, it's not going to detect that random sip of champagne or cooking with wine. This is something that is real, all right, and regular use. It seems to be unaffected by liver function, age, BMI, renal insufficiency, and it really has outperformed other biomarkers in a transplant setting as well, where the stakes are quite high. The cost is pretty high. The turnaround time is about 5 business days, but at least in New York, we haven't had any problems with insurance, kicking this back and making the patient pay for it. In fact, I check it every time my patients who undergo early liver transplant for alcohol-associated hepatitis get a blood draw. So this is, within a year, 10, 15 blood draws of PEth, and it hasn't been a problem. And I think also very importantly, we should start treating alcohol detection or biomarkers like a hemoglobin A1C. Okay, it's not to try to catch them and as an aha moment. Okay, it's really to try to guide the patient who you expect will have relapsing and remitting of their alcohol use disorder, as they're a little out of control. They've had a slip. We need to get them back under control, just like you would an A1C that goes up to 9 or 10. You want to get those sugars under control, right? I think it's a nice way for us to try to conceptualize that. So some of you in the audience may say, well, is this really our job to do this? I'm busy doing other things, right? I'm a little embarrassed to share some of these points in a panel of experts, but in my reading of the literature, alcohol exacerbates irritable bowel syndrome, especially binge drinking. Alcohol may exacerbate IBD symptoms, and we know that alcohol exacerbates NASH. And you could argue that they're kind of two different things, but there are sub-analyses of clinical trial data that demonstrate that those patients who drink 0 versus those within the sort of safe limits of drinking, they have in terms of a natural history study, they don't have as much improvement in steatosis and improvement in liver enzymes if they do drink alcohol. So your NASH patients might actually be ASH patients or a combination of both. Right. So it is our job to try to screen these patients. It does play an impact. So what are some of the therapies for alcohol use disorder that we can provide? Right. So this is stuff that we just do routinely, I think, as GI and hepatology providers. But I wanted to go through some of the data a little bit more in depth. So many of you are familiar with the 12-step programs, Al-Anon, AA. There are community-based peer support programs. We call them relapse prevention programs in our hospital. These are often group and individual sessions with biomarker testing. Motivation, and then a more one-on-one with a therapist, motivational enhancement therapy, cognitive behavioral therapy. I'm not going to bore you with the details, but basically, if your patients enroll and engage in one of these kinds of programs, it increases abstinence rates by 2-fold. Okay. That being said, relapse rates after psychosocial therapy completion is still around 50%. Okay, they go back to drinking afterwards, unfortunately, half the time. So how does that compare between other chronic illnesses? It's actually not that bad. So in terms of if you compare it to hypertension or asthma, this relapse rate is relatively similar to those other those other medical conditions that that we treat. Okay. And so your alcohol treatment expectations may be a little bit different. I think in patients with advanced liver disease, your ideal goal is abstinence. Okay, I think that's quite clear. But in patients, who don't have liver disease, they have low fibrosis, perhaps a more practical goal might be harm reduction. And that is something that is recognized in the addiction community as a viable endpoint in intervention studies. Of course, this may depend on the comorbid status of the patient. So think about this in terms of what you think your expectations should be for the patient. So you could say even more cynically, well, I don't know, I don't want to get involved in this, right? But in fact, you're probably already involved, all right? You're doing probably some alcohol use disorder therapy in the office, even whether you know it or not, all right? And this is codified in a term called SBIRT, screening, brief intervention, and referral to treatment, okay? And so what this is basically, counseling a patient. You screen adults for high-risk alcohol use with the audit C of the single question. If it's positive, you perform a brief intervention. Basically, you interpret the results and the risk to health, high blood pressure, use disorder, liver disease. And then you ask, well, why do you drink? Is it because they're self-medicating for depression, anxiety? Is it related to just, some of the social benefits to it, work-related benefits? And then you assess the motivation to change drinking. It's very similar to, smoking cessation, for example. If the patient is ready for change, you set some goals and you refer them to treatment. That's SBIRT. So many of you are already doing this, okay? And I put it to you that way because there is data that suggests that if you do this in a regimented way, you will reduce heavy drinking beyond recommended limits by about a third. And this is actually a codable, billable, thing in your medical charts, because it's part of the U.S. Prevention Task Force recommendations, grade B. Okay, as you know, grade B is not an easy thing to try to achieve. So this is something you're probably already doing, and something that I'm just promoting with data to continue doing that. There is the concept of the ideal psychosocial therapy for alcohol use disorder, and now I'm adding liver disease, to it. So there was a nice meta-analysis from Fazia Conwall, Baylor, looking at these various interventions in patients with alcohol-associated liver disease. And in essence, cognitive behavioral therapy or motivational enhancement therapy, so a more intense one-on-one type of intervention with medical follow-up, which is basically us, primary care, that was shown to decrease alcohol relapse rates. And the effectiveness was increased if there was an integrated care model. Okay, what do I mean by that? Well, again, the ideal or gold standard is probably something that is similar to what is being seen and done at University of Michigan. All right, Jessica Mellinger, Scott Winder, and colleagues. So basically, it's a co-located multidisciplinary clinic of providers, and you can see 6 different types of providers who are able to see patients. They have this proposed mechanism of how this workflow might work. This is probably not likely for you to be able to accomplish, in the real world in a busy GI practice. But at least it's something aspirational that I believe, and there is data for it, mostly from Italy, that is likely to be the most effective for patients. Okay, so we're not going to have those resources even at Mount Sinai. Outside of a transplant setting, we don't have an integrated clinic yet. But so to try to prepare for this talk, I created this sort of unscientific survey of referring providers, colleagues of mine. I asked them, how do you manage your patients with alcohol use disorder in a GI practice? So the first provider said, I send them to the local AA, they look it up, 2, the second provider, well, depending on their insurance, I refer to 2 potential rehab programs. And the third provider said, well, I send to 2 potential local psychiatrists who tend to take the insurance that my patients, have. Okay. Note that on the other tabs, they don't have access to social workers. They're not in academic practice, and they never prescribe themselves. They never prescribe alcohol use disorder medications to their patients. They say that's not our job. That's a job for someone else. Okay. So in trying to answer the question of how to integrate alcohol screening and treatment in your practice, I really think that outside of a resource-rich academic institution that already has built-in multidisciplinary panels, you should create a go-to alcohol toolkit. Okay, so find some collaborators. Have an inpatient detox unit that you can refer patients to. If it's an outpatient, group versus individual programs, ask your patients, did you like this program? What did you think about that program? Okay. Be sensitive to insurance type, the cost of the program, where it's located, whether language will be a problem. The patient in front of you may speak English pretty well, but to get deeper into addiction coping strategies, triggers, really it should be in their primary language, and see if that's available. resources. Do they have a smartphone where they can use telehealth, which is widely available now? And also whether or not, especially if they have cirrhosis, this program is going to be accepted by their transplant center as, working toward being, time in a program for potential listing for a patient. So for example, in our program, AA is not accepted as a prevention program because biomarker testing is not done regularly. Ask your colleagues, about their go-tos. And if you're starting out and you don't really have any of these resources, use the NIAAA Patient Navigator. All right. So this is a very nice website that does a lot of the work for you. It's linked to the American Psychiatric Association websites and other addiction societies. And if you do a search, I just put in a search zip code for Anaheim, I believe. And there was 1,300 different results that come out of this. All right. And so, and they go through insurance type and distance to the patient. So start somewhere. And I think it could be a very valuable resource. You could also break it down to searching for a therapist with addiction specialists who've had addiction training. Or let's say you have a patient that has comorbid depression or anxiety. They really need to see a psychiatrist rather than a therapist. You can break that down even further as well. Board certified addiction psychiatrist for mental health care. There won't be a lot on that list because I tried, but there will be some. All right. So this is a good resource that I encourage you to use to create your toolkit. Okay. I want to shift gears a little bit away from screening now and psychosocial therapies to alcohol use disorder pharmacology or pharmacotherapy medications. All right. So this is a really important article that came from the NIAAA leadership in 2016. And really, if you're interested in addiction, this is a really nice overview where neuroscience research really increasingly supports the view that addiction is a disease of the brain and not voluntary personal irresponsibility. And because of that, medications should be really effective, just like with depression or anxiety, to be able to reverse some of these effects or get it under control. Okay. So here are the FDA approved medications for alcohol use disorder. There's only 3 of them. All right. And you can see, disulfiram is the one that we all learn in medical school. It's been around for a long time, but in our patients, we tend to shy away from it because they can stop it and they don't have to have that disulfiram-like effect. And there is significant hepatotoxicity, particularly in patients with advanced fibrosis. And I'll go through the other 2 in a second. And then there's a bunch of off-label medications as well, baclofen, gabapentin primarily, which I'll touch upon very briefly. But even some of these other medications like Zofran has been used for alcohol use disorder. So it's a big list, so I'll try to distill it down to some of the most important ones. So pre-treatment detox or abstinence is always preferred but not required. I think naltrexone is probably the most effective. It's probably the most potent, okay? Especially for patients who are still drinking. It's better for harm reduction. And there is a long-acting depot or Vivitrol form of naltrexone. Acamprosate, which is a newer kid on the block, is probably better than naltrexone for maintaining abstinence. So you'll see this one more commonly in patients who've completed an alcohol detox program. They're put on acamprosate and then they come to see you and you're not really sure what to do with that, right? One of the issues with acamprosate is that it requires renal dosing. It's newer on the block, and it's 6 pills a day. So you have to have someone who's very, very motivated to take acamprosate. All right, TID dosing. That being said, it's likely that naltrexone and acamprosate are pretty similar in efficacy between relapse, slips, and the percentage of heavy drinking days. Of note, the black box warning for naltrexone, both oral and injectable, was actually removed about a decade ago. All right, so the concerns about hepatotoxicity, it still lingers, just like with statins, for example, in liver disease, but that's actually long gone. Okay. But even amongst my colleagues, they're not very excited about prescribing naltrexone. And then disulfiram is FDA approved, but not recommended in advanced liver disease. So what about pharmacotherapies for alcohol use disorder in patients with alcohol-associated liver disease, particularly advanced fibrosis? Well, basically, there are none. Right? You'd expect that there would be some because these are the highest risk, highest stakes patients, and we should be studying this, but there are none. There's only one positive clinical trial in cirrhosis, and that is with baclofen, an often used muscle relaxant medication. All right. This study from Italy and Adelarato showed that there was a decline in relapse in patients with cirrhosis. There were no hepatic encephalopathy episodes, but you have to, if you're going to try this, you have to really titrate up even to the point of 120 milligrams TID. So you can't just stick to the 10 milligrams and say they failed. So I wanted to share you how I treat alcohol use disorder in 2020. And I think this is a more practical approach than trying for the first time a camprosate or naltrexone and the concerns about safety and monitoring. So first, I discussed the data on ideal treatment, outpatient therapy plus medical follow-up, which just described. And then I also described to the patient, beyond me assessing your liver health, medical follow-up includes alcohol medications, which will decrease drinking days, relapse, and cravings. And my addiction colleagues describe this as the medicalization of alcohol use disorder, right? Rather than you just got to stop drinking. I don't care. Just you're gonna kill yourself. Making these sort of absolute kind of statements. You say, hey, this is a disease just like diabetes. I have a medication for you. You should try this. Okay, it may not always work, but this is something that you need to do. And my addiction colleagues say it's amazing how, despite people losing their jobs and family life from their drinking, when it comes to affect, information about alcohol affecting their internal organs or their liver, God forbid, they tend to treat it differently. There's something that is triggered in terms of motivation. So we're trying to promote that. Okay, why are we treating it differently than our other, medical conditions we're treating? And then I recommend a trial of AUD pharmacotherapy, and I usually start with gabapentin. All right, now this is off-label. It's not naltrexone, camprosate. It's not baclofen. I've tried baclofen. I don't feel like it works very well. So I've come to gabapentin because I can tailor the dosing to the patient. These patients invariably cannot sleep well at night. All right, so gabapentin is a very good, aid to help with sleep. Depending on the patient and whether they have liver disease, I go from 100 or 300 milligrams started at night. Try it out. People are very accepting of that. You can try gabapentin as a rescue for cravings prior to high relapse situations. The barbecue, the night out with friends, and then you can take it 3 times a day if cravings are frequent. Gabapentin is off-label use by many addiction specialists for outpatient withdrawal treatment as well. Patients can drink on gabapentin and they won't stop breathing. All right, so it's very, very safe. It's familiar to us, even though we're gastroenterologists, hepatologists. We've probably at some point prescribed gabapentin in our training, okay, in our practice. Low addiction potential, very easy to use, and the cost is very low. And lastly, I'll point out that patients tend to like gabapentin because they feel something. A camprosate and naltrexone, it tends to blunt their desires, cravings, and they feel kind of flat. Whereas with gabapentin, they're more relaxed. It's almost like a chill pill, a Xanax, so to speak, but much safer. All right. And for some reason, our patients want to feel something in absence of alcohol. Okay, so I presented all this stuff to you, but does alcohol treatment actually impact survival in alcohol-associated liver disease? And there's some newer data that suggests yes. So there's a large VA study from the Pittsburgh group in patients with cirrhosis and newly diagnosed alcohol use disorder. And within a 6-month period, a very small proportion of them received psychosocial or pharmacotherapy interventions. But in those who did, there was a significant decline in liver decompensation and long-term all-cause mortality. And a study that just came out last month or two from MGH looking at their database of patients, including with or without liver disease, getting some kind of AUD pharmacotherapy. They did include gabapentin, so there probably is some muddiness of the water there. But they demonstrated that in those who were treated, there was a decreased incidence of alcohol-associated liver disease and liver decompensation, as you can see in this Kaplan-Meier curve. So, these are some larger big data sets that suggest that there is an impact. Yes, some of these may be related to motivation to take these medications, and so they tend to be better patients to try to reduce their drinking. But 13% is really not acceptable, particularly if it's impacting survival. So here's a treatment algorithm for alcohol use disorder that I've proposed. So if you have mild alcohol use disorder to the left, brief intervention, SBIRT, consider psychosocial therapy. Usually that's enough. However, if they have moderate or severe alcohol use disorder, consider if they have withdrawal. If they do, you really need to refer them to an addiction psychiatrist, a specialist, or an inpatient unit. If they don't need detox, because they're not really with having withdrawals, without liver disease, really the standard of care should be the FDA-approved medications, naltrexone, acamprosate. However, if they have cirrhosis, then really probably the best data is for baclofen, acamprosate, because it's more renally dosed rather than hepatic metabolism, and also my current favorite, gabapentin, with psychosocial therapies, of course. So some of you in the room may be saying, I haven't been doing this, this is really not in my wheelhouse or on my radar. And so we wanted to know how providers treat alcohol use disorder with concomitant ALD. And so this is a study from last year where we asked in 33 states, over 400 physicians, GI, hepatology providers. Most of them were in academic centers, okay? This question, how are you treating, right? And the survey demonstrated that less than half are using these biomarkers, okay, or single answer screening question, audit C. Interestingly and maybe this is a problem with the question, but almost a half believe that safe alcohol use existed in liver disease, which I showed you data is not the case. 3/4 or so routinely refer patients for behavioral therapy, which is good. And though there were many questions about alcohol use disorder pharmacotherapy, basically no GI or hepatology providers are really prescribing this, okay, which is not so much of a surprise. But I think we figured out the answer. The answer is really half lack knowledge about FDA-approved medications, and we're not trained to do this. So it's not really surprising that we haven't been really implementing this in our practice. But clearly, this is something that needs to change, because whether we like it or not, Hep C may be going away, but alcohol, the other fatty liver, NASH, is here to stay, okay? And the interaction between the two. So again, is this really our job? Should we be prescribing alcohol use disorder pharmacotherapy? Well, I think the answer to that is if access to mental health care is suboptimal, and there's data that suggests that medications can increase survival, especially in our liver disease patients, then the answer is yes. I would also say that if we're pretty comfortable prescribing things like, tricyclic antidepressants for IBS, biologics and IBD, some of you are probably prescribing GLP-1 receptor agonists for NASH, right? We've used interferon for hepatitis C in not so distant past. If we're used to using and prescribing these toxic or difficult medications with a lot of side effects, I think we can get away with a little bit of gabapentin at least, right? And lastly, for our cirrhotic patients, we are the last line of defense for them, right? So what else are you going to say except for you must stop drinking? You want to try to offer them something else, okay? And I'll end with this last bit of trying to convince you about this. The Lille group in France demonstrated that if a patient survived a bout of severe alcohol-associated hepatitis, in the first 6 months, you wear your hepatology hat, Lille score, MELD score, response to steroids, we're used to that kind of stuff. But after 6 months, really, it's our psychiatry hat, alcohol relapse was the thing that predicted whether a patient would survive or not, okay? And so if their bilirubin's better, then you really need to focus less on the liver and more on their alcohol use disorder. And even if you're not a hepatologist, say, I don't really see liver patients, well, I found this older study that demonstrated the rising incidence of alcohol-associated pancreatitis in the United States, greater than 50% increase. And this is old data. And I'm sure with COVID, that has steadily increased as well. That's a study that's waiting to happen. All right. So you're going to see this and need to deal with this, even if you're not a hepatologist. So here are my key takeaways. Overall, alcohol is probably not healthy, but likely okay at 1 drink a day, preferably with food. Okay. The tide of alcohol use disorder and ALD are rising. And I hopefully try to convince some of you that to start integrating alcohol treatment in your practice in terms of screening, ask that one question, the single answer screening question. Start to check PEths. You'd be surprised at how many of your NASH patients are drinking very heavily, and that's positive, or your PBC patients or whatever. Treat it like a hemoglobin A1C afterwards. And in treatment, have your list of go-tos in terms of your resources for your patients with alcohol use disorder or alcohol-associated liver disease, both for psychosocial interventions and medications. And I'll end here. Thank you.
Thank you, Gene, for that very interesting talk.